Okay, guys, this is the last recording for the heart. We're going to talk about cardiac output and regulation. So the heart undergoes an average of 60 to 80 cardiac cycles or beats per minute. That's one way you want to think about this. Each beat is a cardiac cycle. And this particular value is known as your heart rate. The heart rate is one determinant of cardiac output. Cardiac output is the amount of blood pumped into the pulmonary and systemic circuits within 1 minute. Cardiac output is also determined by the amount of blood pumped in the heart in one heartbeat. Okay, so the amount of heart pumped into one heartbeat is referred to as the stroke volume. So if you were to take the stroke volume, the amount of blood, times it by the heart rate, the amount of times you go through the contraction cycle, cardiac cycle, and this will allow you to be able to calculate your cardiac output for the ventricle. And that's what we're concerned about, is really ventricular cardiac output, specifically left ventricular cardiac output. The stroke volume can be calculated by subtracting the amount of blood in the ventricle at the end of the contraction, which is referred to as the end systolic volume, from the amount of blood in the ventricle after it has filled during diastole. Diastole is resting, which is the end diastolic volume. In an average heart, the resting stroke volume is equal to about 70 mils. To find out the cardiac output, you want to multiply the heart rate by the stroke volume. So if we have 72 beats per minute, which is your heart rate, times 70 mils per beat, which is your stroke volume, that comes out to about 5,040 milliliters, or about 5 liters per minute, which, if you guys remember from the blood chapter, that's about as much blood that exists in the body. So your blood pretty much circulates through the entire body every single minute. The resting cardiac output averages about 5 liters per minute. The right ventricle pumps about 5 liters into the pulmonary circuit, and the left ventricle pumps the same amount into the systemic circuit in 1 minute. The normal adult blood volume, again, is about 5 liters. The entire supply of blood passes through the heart every minute. Now, some factors that can influence stroke volume. Stroke volume averages about 70 mils per beat. It can range from 50 to 120 mils. The exact stroke volume may be difficult to measure directly. Oftentimes, measurement is called an ejection fraction, which is used in its place. And you might have heard, if you've had anybody or family members that maybe have cardiac issues, they sometimes might screen for the ejection fraction. The ejection fraction is the percentage of blood out of the total amount that is ejected with each ventricular systole. It is equal to the stroke volume divided by the end diastolic volume. Normal ejection fraction is about 50 to 65%, and this value should be equal for each ventricle. I've seen that some people that have congestive heart failure, their ejection fraction can be as low as 10 to 15%, in which case they are really getting to the point of not being able to perfuse their tissues very effectively. Now, there are 3 factors that can influence stroke volume: preload, heart contractility, and afterload. Preload is going to refer to the length or the degree of stretch of the sarcomeres and the ventricular cells before they contract. This is largely determined by the end diastolic volume, which again is the amount of blood that has drained into the ventricles by the end of the fill stage, or the diastole. There are 2 factors that influence the end diastolic volume: the length of time the ventricle spends in this diastole, and the amount of blood returning to the right ventricle from the systemic circuit, which is referred to as your venous return. The end diastolic volume increases when the ventricles spend more time in diastole because there is more time to fill them with blood. The left ventricle pumps more blood more forcefully into the systemic circuit because of the additional blood returns to the right atrium more rapidly, increasing your overall venous return. The relationship between preload and stroke volume is explained by the mechanism known as the Starling Law. According to this law, increased ventricular muscle cells stretch. This leads to more forceful contractions. Stretching causes more optimal overlap of actin and myosin filaments in the muscle cells. This enables stronger contraction and a higher stroke volume. This ensures that the volume of blood discharged from the heart is equal to the volume that enters it, particularly important during exercise when cardiac output must increase in order to meet the body's needs. Second factor that influences stroke volume is contractility. This is the heart's intrinsic pumping ability or ability to generate tension. This is difficult to measure directly, and it can be estimated clinically by examining the velocity of the blood being ejected from the ventricles. Increasing the contractility will increase stroke volume and therefore decrease the end systolic volume. Decreasing contractility will do the opposite, decreasing the stroke volume and therefore increasing the end systolic volume, assuming that the preload and afterload remain constant. Agents that affect contractility are known as inotropic agents. Factors that increase the heart rate, such as the sympathetic nervous stimulation, often also affect contractility and so increase the force of the contraction. When the heart rate is too high, contractility decreases, as does the preload, as the heart is beating too rapidly to develop significant tension during each contraction, and a decrease in both the stroke volume and the cardiac output occurs. Stroke volume and the heart rate generally will increase together. The third factor that influences stroke volume is afterload. This refers to the force that the right and left ventricles must overcome in order to eject blood from their respective arteries. So in this situation, what you want to think about is that you're going to have certain pressure of blood in the aorta, for example. In order for the ventricle to pump that blood out into the aorta, it has to overcome that pressure that's already there in the aorta. This is largely determined by blood pressure in the arteries for both pulmonary and systemic circuits. As the afterload increases, ventricular pressure must be greater to exceed the pressure in the arterial, pulmonary, and systemic vessels, and open the semilunar valves then. The only way those valves will open is if the pressure is greater in the ventricles than it is on the opposite side. An increase in the afterload, therefore, generally causes a decrease in the stroke volume and a rise in the end systolic volume of the ventricles. Conversely, a decrease in the afterload generally corresponds to a higher stroke volume and a lower end systolic volume. So again, the three factors that can affect stroke volume are preload, contractility, and afterload. Again, preload is determined by the volume of blood coming in from the pulmonary circuit. Contractility, this is determined by the heart intrinsic pumping ability. And afterload, this is determined by the blood pressure within the systemic circuit. High preload leads to high endostolic volume. Volume of the blood stretches the cardiac muscle cells, combined with increased contractility, leads to a more forceful contraction. Since afterload is low, this forceful contraction isn't pumping against a great deal of resistance. A forceful contraction against a low resistance leads to a high stroke volume and a lower end systolic volume. Notice that a low preload leads to a low endostolic volume. So cardiac muscle cells are much weaker, much less stress, combined with diminished contractility, and overall the heart will contract weakly. Since afterload is high, presumably due to high blood pressure, the weak contraction is pumping up against a great deal of resistance. A weak contraction against a high resistance leads to a low stroke volume and more blood in the left ventricle after, which gives a high end systolic volume. If you look, there's more blood there left than if you had a high preload with a low afterload. Ventricular hypertrophy. This is a long-standing increases in preload and afterload are associated with an enlargement of the ventricles. Cardiac muscle cells of the ventricles need to generate more tension to continue pumping against a higher afterload. Cells respond same as the skeletal muscle fibers when they have to generate more tension, make more myofibrils and more organelles, and as a result, they get bigger. Right ventricular hypertrophy most often results from respiratory disease or a higher than normal blood pressure in the pulmonary circuit, meaning that the right side of the heart is more enlarged. The left ventricular hypertrophy generally results from high blood pressure in the systemic circuit. Ventricular hypertrophy can increase the effectiveness of the heart's pumping up to a certain point. Condition decreases the heart lumen and so filling space. Increases risk for many other cardiac conditions, including heart failure. Now, factors that can influence the heart rate. Other determinants of cardiac output is heart rate. Under normal conditions, the rate at which the SA node generates action potentials determines the heart rate. Factors that influence the rate at which the SA node depolarize are known as chronotropic agents. Anything that increases the rate at which the node fires is called a positive chronotropic agent. This includes the sympathetic nervous system, certain hormones, and elevated body temperature. One with opposite effect is known as a negative chronotropic agent, and this includes parasympathetic nervous system and decreased body temperature. Although the heart is autorhythmic, it still requires regulation to ensure that cardiac output meets the body's needs at all time. This is regulated primarily by the nervous and endocrine systems, which influence both the heart rate and stroke volume. The two branches of the autonomic nervous system regulate our autonomic functions. The role of the sympathetic division of the autonomic nervous system includes the following. It innervates the heart via a set of sympathetic nerves that stem from the ganglia located along the spinal cord. The neurons release neurotransmitter norepinephrine. This will increase the cardiac output with both positive chronotropic and inotropic effects. Norepinephrine's positive chronotropic effect increases the heart rate by raising the rate to which the SA node fires up to 180 to 200 or more times per minute. This also increases entry of calcium ions into the cardiac muscle cells. Higher calcium ion concentrations increases the contractility of the cardiac muscle cells. In turn, it will raise the stroke volume. Together, these two effects can dramatically increase the cardiac output. Parasympathetic nervous system exerts essentially opposite effects on the heart. It innervates the heart by the left and right vagus nerves, which is cranial nerve number 10. They release acetylcholine, which primarily affects the SA node, decreasing the rate of action potential generations. This slows the heart rate and can even stop the heart temporarily if parasympathetic stimulation is strong enough. The vagus nerves primarily innervate atrial muscles, have less effect on ventricular contractility, than on heart rate, therefore only weak negative inotropic effects. And here you can see the positive and negative effects on the heart rate there. Hormonal regulation. The adrenal medulla is activated by the sympathetic nervous system, and in response it secretes hormones epinephrine and norepinephrine into the bloodstream. The hormones will have the same effect as the sympathetic nervous system neurotransmitters, positive inotropic and chronotropic agents, but the effect is longer lasting than the sympathetic stimulation. As we've talked about, endocrine stimulation is a much more long-lasting effect. Other hormones that have positive inotropic and chronotropic effects include thyroid hormone and glucagon, both of which is produced by the pancreas. The amount of water in the blood, your blood volume, plays a significant role in determining the heart's preload and therefore the strength of its contraction. Hormones such as aldosterone and ADH increase blood volume and therefore preload, and so raise the cardiac output. ANP decreases blood volume and preload, and therefore reduces the cardiac output. Other factors that can influence the cardiac output include the concentration of certain electrolytes in the extracellular fluid, which plays a large role in determining the length and magnitude of an action potential and cardiac output. Body temperature influences cardiac output. The SA node fires more rapidly at higher body temperatures and more slowly at lower body temperatures. Other factors that influence cardiac output are age and physical fitness, which can influence the heart rate and cardiac output. Younger children and elderly often have higher resting heart rates. Trained athletes often have much lower resting heart rates. Exercise will increase the stroke volume, so for the body to maintain constant cardiac output, the heart rate must decrease. And here's a little schematic that sort of goes over the overall regulation of cardiac output. Now, the final few slides, I just want to go over some things referred to diseases of the heart, and one in particular is heart failure. This is any condition that reduces the heart's ability to function effectively as a pump. Causes of heart failure include reduced contractility due to a myocardial ischemia and/or a myocardial infarct, valvular heart diseases, and any disease of heart muscle itself, known as cardiomyopathy, and electrolyte imbalances. Heart failure generally results in a decreased stroke volume, which in turn reduces cardiac output. Signs and symptoms of heart failure generally depend on type of heart failure and the side of the heart that's affected. In the left ventricular failure, blood often backs up within the pulmonary circuit, known as pulmonary congestion. The backup of blood flow increases the pressure in these vessels, driving fluid out of the pulmonary capillaries into the lungs, called pulmonary edema. Both the right and left ventricular failure may produce similar findings in the systemic circuit, where you end up with peripheral edema, or buildup that backs up in the periphery. This is something that we can refer to as congestive heart failure. When somebody is in full-fledged congestive heart failure, you start to see swelling up in the legs and the feet. This is mainly due to gravity. That's where you typically will see this. Peripheral edema is exacerbated by the fact that the kidneys retain excess fluid during heart failure because they're trying to increase the overall preload and compensate for the lower cardiac output. Treatment for heart failure generally is aimed at increasing cardiac output. Lifestyle modifications are number one. This may include weight loss and mild exercise, plus dietary sodium and fluid restrictions. There is a multitude of drugs that can help to correct a lot of the issues that could affect overall cardiac output. Drug therapy increases cardiac output in one of at least three ways: decreasing the abnormally high preload by promoting fluid loss from the kidneys, such as Lasix, increasing the heart's contractility so that it pumps more effectively, and decreasing the afterload so that the ventricles have to pump against a lower pressure. This is getting the overall blood pressure down too. So it's not uncommon for somebody that's in heart failure to maybe be on a water pill or / high blood pressure pill. In some cases, a heart transplant or surgically implanted pacemaker that electrically stimulates and paces the heart may be necessary. Okay, and that is everything for the heart. Next up will be blood vessels. Have a good one, guys.